Wow. It's hard to follow that up. I mean, all the great information and all the great timing and comedy and jokes. I thought I was pretty funny on the radio, but you should take my show anytime in the morning. Same here. Reason why I'm not on Fox 29, 92.5 XC radio. Thank you so much, Carol, for that. Let's give her another round of applause. This is amazing. And as she so lovingly said, she will be here, so make sure to go to the table. Now, you're more than welcome to hang out here. You're more than welcome to explore our vendor tables, but at 1:15, so about 20 minutes from right now, we're going to do our digital health in the ALS clinic with Dr. Andrew Geronimo and Dr. David Lacomis right here in the main ballroom. That starts in 20 minutes at 1:15, and then another set of programs again at 2:15. So feel free to explore, make a new friend, talk to Carol, talk to each other, go out, check out our vendor tables, and we'll meet back here for another great program just about 20 minutes.
My grandfather, I remember his first symptoms of ALS in 2004. We were at my dad's birthday party in December of 2004, and my grandfather, Regis Heil, he stumbled, seemed odd, he was acting a little bit differently, and then after a few months, he was diagnosed with ALS in 2005. And as many of you have told me today, that diagnosis process often takes way too long. But thankfully what you have at the end are wonderful doctors, social workers, caregivers who are there for you. And one of those people is who I get to introduce today. As my grandfather's disease progressed, I'd visit him and help give my grandmother a break, which we all see how important those breaks are for our caregivers. My dad would take him to his clinic appointment, so I never went, and I never got to meet who took care of my grandfather. That's where they met Dr. David Lacomis in UPMC in Pittsburgh. ALS has caused a lot of pain and stress for our family. It was very difficult wondering what the next steps would be as the disease progressed, and he eventually passed away in 2007. But my dad was able to meet a wonderful person and a great expert in ALS care who is still actually using my grandfather's brain today to help advance ALS research. That man is Dr. David Lacomis. David Lacomis spoke about my grandfather when we met a few months ago talking about ALS research. And my dad always talked about the kindness and reassurance that Dr. Lacomis brought to our family at a time of need. Dr. Lacomis is a professor of neurology and pathology at the University of Pittsburgh School of Medicine. He is also the director of clinical research for the Live Like Lou Center for ALS Research. Today I had the privilege of meeting Dr. Lacomis for the first time, so it was just not a name that I heard in my family. He has been the principal investigator in 10 ALS trials across a broad range of topics, including neurotechnology, which he'll talk more about today because I can't explain that myself. He will be joined later by another exceptional researcher, Dr. Andrew Geronimo, who many of you also know for his research into things like brain-computer interface. Dr. Andrew Geronimo comes to us from Penn State College of Medicine, where he is an assistant professor in the departments of neurology and neurosurgery. So in 2020, we recognized Dr. Geronimo with our Flame of Hope Award for ALS Research and Innovation for his work on advancing technology and communication for people with ALS. As you remember in 2020, I'm not going to go into details about that year, but we had to go to his house and meet him and do things in recording, and he is and he's an expert in ALS technology and care, welcomed us into our home, and now we're happy to welcome him into our home here today. Dr. Geronimo and Dr. Lacomis will talk about the digital health in the ALS clinic and the COMMAND trial, which involves brain-computer interface. These experts demonstrate how the top minds in ALS research are collaborating to find solutions for ALS families. This presentation will show why there is great hope for the future of ALS care and technology. Dr. Lacomis is going to speak first, then Dr. Geronimo, and then we'll have some time for questions. So with that, please join me in welcoming Dr. David Lacomis up here today.
Thank you very much for that heartfelt introduction. That was quite a memory. I come from the western part of the state. I'm not going to ruin this by talking about sports allegiances. I don't do comedy, but I do have an appreciation for sarcasm. So, My disclosures, I have nothing personal regarding to the study. I don't have any financial, I have no stock in the company that's making this device, but the study is funded by NIH. I do get royalties for something else, and my main disclaimer is that I'm a clinician. I'm not a bioengineer. I have no idea how this stuff works. I'm only going to tell you how we're using it and what's happening with the study. Dr. Geronimo will take all the questions about the bioengineering aspects of brain-computer interface. But I do have to tell you the basics of what this is if you don't already know, and how we're using it and why we're doing it in a certain way. So basically, brain-computer interface means that we're taking activity, signals of brain activity, and decoding them so that patients are able to use digital devices by just thinking about performing a motor task. Think about that. So instead of using your hands or your feet to use a keyboard or a mouse, you're actually thinking about making that movement, and that is creating the motor task to occur on a digital device. I'm not talking about moving a chair or doing something like that, but using these digital devices to basically improve quality of life. And that's really what the goal is. And it's not just for ALS, it'll be for patients with all types of paralysis, really. So the way I think about it is anything that you could do with your hand on a keyboard or on your cell phone, you're now doing with your brain. So you can surf the web, you could send a text, email. If you are so lucky to have a smart home that's rigged up so that a computer can turn on your lights, turn on your oven, open your door, you could do all that just by your thoughts. So how do you access these brain signals? So you have to get to the signals which are emanating from the motor part of the brain, so the motor neurons inside the brain. So more commonly, this has been done invasively by making a hole in the skull and then implanting the electrodes directly into the brain. You could see on this slide what these electrode arrays look like. They're small, they're smaller than the tip of a finger, but the invasive ones still require at least a hole to put these in and then connect them to an external wire or another external device. I think they could probably be done wirelessly at some point. But that's kind of been the main way to get these signals, so invasively, at least to get the better signals. You could also do this non-invasively. So EEG type electrodes could be put on over the brain to capture signals. It's not quite as accurate as getting them invasively obtained. And then there's a sort of an in-between way, which is the way we're doing it. So you have veins that go over the brain called sinuses, and they can capture brain signals, and you can get to these veins going through the jugular vein in the neck. So if you go into the jugular vein and put a catheter all the way up over the head, you can get inside the skull, basically right next to the brain or on top of the brain, without going through the skull. So it's somewhat invasive, but not nearly as invasive as cutting open the skull. So this is the type of device called a stentrode, which was invented to go inside the vein. So the electrode array, instead of implanting it on the brain, is implanted inside one of these veins. So the relevant anatomy to how this works is something I've had to think about, so I'm going to have to give you a little bit of an anatomy lesson here. So if you look at the left side, I don't think this pointer is going to work, so forget about that. So if you look at the bottom middle panel, all the blue stuff, those are all the veins that go over the brain and around the brain. So we can get to the upper middle part called the superior sagittal sinus through the jugular vein. And that's in the middle of the brain. Now, the brain has a map inside of it. You may not know that, but you have a map in your brain. So if you look at the bottom right panel, you'll see the distribution of the body parts that are represented in the brain, in the motor neurons of the brain. So you see the foot is hanging right over the middle part. So when you think about moving your foot, you're activating those motor neurons in the middle part of the brain, and then as you move laterally, which is to the outside, to the left, you see the hand. So the major hand motor neurons are a little bit off to the side. So they're not exactly in the middle, but they're probably close enough to get some of those signals. So if you can get a recording array through that vein that's close enough to record the signals from the foot area or the hand area, just by thinking of that task, you can actually cause activation of those motor neurons, which will be the signals will be collected by this device, which is called the stentrode. Now, we know that these areas activate when patients perform a motor task because we do functional MRI scans on these patients before they get the stentrode. So if you look on the top middle where it says Collinger, that's my colleague at UPMC. So she does functional MRIs, and you could see the hot area, which is the bright yellow area, and that's the part of the brain that this patient is activating by just thinking about performing a motor task, moving foot or moving hand. So our target to get the stentrode is going to be adjacent to those areas. So the neurointerventional specialist will then take a catheter and put it into the neck, and you could see the arrows on the left-hand side. So it goes up the jugular vein, around the back of the skull, this is inside though, and ends up near the middle, sort of the mid-skull area about right here, which is going to be close enough to the motor cortex to capture these brain signals. Now, the person who invented this is an Australian by the name of Tom Oxley, and he's shown on the right. So he came up with this idea. He pioneered that with his colleagues. They got some investors together, and they performed the first in-human trial in Australia. So you could see a patient who's seated there at a computer, and the stentrode device is inside the skull. You could see the images showing you the blown up areas where the blue is, that's the vein. So the device is inside, and the patient is now communicating through these wires. The wires are they come from the inside out, but they're tunneled under the skin. So the patient has the device go in through the neck. The wire that is coming down to communicate with the computer is tunneled under the skin and put in a device in the chest wall, kind of like a pacemaker. It's called the IRTU, that's the internal device. Then there's another device put on the outside that interfaces with that without a direct connection. It uses infrared. And then that goes to the device, which is that magic box that Dr. Geronimo knows about that I don't understand anything, that decodes these signals and then interfaces with the computer so the patient can directly interface brain to computer. So they did this successfully and published this study in JAMA Neurology in 2022. They call that study the switch study. So I'm going to talk a little bit about that because I can't tell you everything that's happening in the current study because it's an ongoing study and we're not allowed to give you all the details. But basically, I'm just going to tell you that we're finding the same stuff that they found in the previous study. Okay, so you could just sort of make that assumption and go from there. So they included 5 patients, 4 with ALS and 1 with primary lateral sclerosis, and they published the results of 4 finally. And the bottom lines are there were no significant adverse events. Okay, so the 2 things you worry about with this is you're putting a device inside the skull, and it might cause a blood clot. So you're worried about blood clots. They didn't see that, and you're worried about the device migrating. And they didn't see that either. So patients get followed over time with serial angiograms, venograms, to make sure that the device hasn't moved, and it didn't. There were no deaths due to the procedure. There were some things that happened because of putting the device under the skin, some risk from that, some bleeding and so forth, but no major adverse events. This just shows you some pictures of where the device is. It's in the appropriate place. It didn't move. There were no blood clots like I told you. So the information that they found out from the study, looking at the way the signals were characterized and what they could do, was they found out that the signal was stable, and then the patients were able to use the implant for routine digital activities. So they were successful in doing texting, emailing, personal finance, online shopping, and communication of their care needs with the caregiver. So all the things that they were hoping to do. And basically there were no major complications like I told you about. So the study went on for 12 months. There were no major complications. The company then approached the FDA about doing a study in the United States. So we were involved in the planning stages of this for almost 6 years before it actually happened. So that's how long it took to negotiate, what kind of patients we were going to study. There's an interest in studying this in ALS, so that's why we we chose ALS, and they wanted patients with advanced disease because it's a safety study. They didn't want to risk putting the device in patients with early disease. So we only were allowed to put in patients who had very advanced disease at the beginning stages. And the person who got the primary grant is a bioengineer from CMU named Dr. Weber, and we worked with him, and then the team at Mount Sinai, where Dr. Oxley is now, and then we added the University of Buffalo later, and we were allowed to enroll 6 patients in the study. This is showing you a functional MRI scan of one of our patients and showing you the activation in the midline, which is what you hope to see. All 6 patients have now been implanted. Before we could implant the patients, we had to have the functional MRI showing the brain activity where we want it to be. We had to show that they had normal anatomy, so there wouldn't be a blockage, so you wouldn't be able to get the electrodes in the right area. And then there are about 20 other things that I'll tell you about briefly in case any of you are interested in having this done in the future about the inclusion and exclusion criteria. So the current patients are being monitored for safety, and they are using the device. And if you Google CNN Stentrode, you will see Sanjay Gupta's interview with our second patient who's been implanted. Has anybody seen that? So no, it was supposed to be at a certain time on TV, and then it got bumped by some election, so nobody's seen it. But it's very easy to Google. It's like a 5-minute thing. I won't be able to show it to you today because I don't have enough time. But I could tell you what he told him, so that's basically what's happening with the study. So he can text, he can email, he can use his phone in different ways. Basically, whatever you could do typing, he's able to do now, and he can play Pong. He cannot play any more sophisticated video games than that. And it's taken him about 2 months to get to that point. So you don't put this thing, a switch turns on, and you do all this stuff overnight. There's a lot of training that goes into it. But you could look at that, and then that basically tells you how at least he's doing. I can't really tell you about all the other patients because that's still proprietary at this point. But another study is being planned. I'm going to show you the link. People who are interested could sign up on the Synchron website, showing that they have interest in the pivotal trial, which is going to be multi-center, multinational study. But basically, you cannot have any contraindications to angiogram. You have to be a candidate for anesthesia. Health has to be reasonable. You can't have an increased clotting or infection risk, like a wound healing problem, so diabetics may not be allowed. If you're on immunosuppression, you probably won't be able to get into the study. Patients who have significant dementia probably won't be able to get on. The breathing has to be probably at least 50% of normal, or patients on ventilators could probably be in. These are all the criteria for the current study. I don't know what the criteria will be for the new one. The other thing you need to know is that once you have this implanted, it stays in forever, and you can never have an MRI scan once this goes in. So that's basically the study in a nutshell. There's a lot more to it than that, obviously. I just gave you the highlights. It takes months to get all this stuff set up, making sure that we know the anatomy, that it's going to go in the right place, that the brain activates, that it's safe for the patient, that we have a big team involved. It's done in the angio suite, so patients have to go under general anesthesia. The procedure itself, the whole thing takes about 4 hours just because you have to get this in the right place. The main catheterization is in a vein, but they also do usually an arterial catheterization to do an angiogram. And then successfully, this is from the Synchron website, showing you the arrows line up on this screen with the anatomy that I was showing you, so they could, our skilled neurointerventionalists can get this device within a couple of millimeters where it's supposed to go. But it takes a lot of overlying of different imaging techniques to figure that out. And that's just a still image taken from the CNN website where our patient was being interviewed. And the other thing I want to mention is when we started the study, the inclusion criteria were patients had to be paralyzed in all 4 limbs. So they had to be paralyzed in all 4 limbs, but still either breathing decently or on a vent. There aren't a lot of ALS patients that meet those criteria. So we were allowed by the FDA to modify the criteria to get patients who just had paralyzed arms. So that's the man in the barrel phenotype that some of you may be familiar with. And patients who have that may often have normal breathing, can talk, legs may still work, and that's what this patient has. And you'll see him on the CNN presentation. So once we did that, we were able to fully enroll the study. So I imagine the next phase will have similar inclusion criteria. Takes a really big team to do this. That's just the size of the team at UPMC, and now there's teams at Buffalo and Sinai as well. And I would have to say personally, my favorite part of the study, we heard from Mr. Heil about how things come around, but my son was the anesthesiologist on the case. Just by accident, he's a resident. He just happened to be on the rotation that week that allowed him to be in the OR for this procedure. This was the first case that was done, so that was pretty exciting for me. So we'll take questions at the end of this, and I thought I had the link to the Synchron. There it is. No, that's not the one. There's another one I can give you later. I think it's synchronbci.com is where you can go, https://synchronbci, and it'll allow you to register with their site, and then they'll keep you informed of the progress of the next study. Thank you very much, and let Dr. Geronimo come up.
Thank you very much for inviting me here today. My name is Andrew Geronimo. I'm a researcher at the Penn State College of Medicine in Hershey, PA. I work with the clinic there, the Hershey ALS Clinic, and it's great to see some familiar faces here today. I also tried to coordinate my tie, but I think I got it a few shades off. I'm going to talk about my studies that I'm running in the ALS clinic that focuses on the use of digital health, whether it can be used for the care that we deliver to patients, or as Carol described in her ALS TDI talk, revolutionizing clinical trials and the way we approve drugs. I have no financial disclosures. This was kind of motivated pre-pandemic, actually, about how we can improve multidisciplinary care that we deliver to the patients in central Pennsylvania. The benefits of multidisciplinary care are that it extends survival compared to seeing your PCP for your ALS diagnosis. It improves quality of life, and it gives you access to research. There are drawbacks. Some people have to spend a lot of time getting there. It's fatiguing, and it's a lot of distance traveled for a lot of people who come to the clinic. So we thought, why can't we use some of this modern technology, some of these digital tools and technology to improve the access to ALS care, reducing burden, and improving quality of life? I'm going to talk about 3 of those projects here today. Measuring respiratory health outside the clinic, measuring mobility, and measuring speech and swallowing. All things that are very important to people who've got this diagnosis. One of the first studies we did was looking at whether we can reliably measure spirometry in the home. So the first study we did is we had patients perform a regular pulmonary function test in clinic, and then we had them self-administer one also in the clinic, but kind of in a separate room, just to show that we got similar results. The diagonal lines here, if they were perfectly on the diagonal lines, it would mean that the standard results match perfectly with the experimental or the self-administered results. So this study gave us confidence that we could replicate a forced vital capacity test and a maximal inspiratory test, inspiratory pressure test, outside of the clinic. So the next phase was to do a 12-month study in the home where we gave patients this device. We trained them for 4 weeks. We did video conferencing with them, but then we let them do their own spirometry measurements in the home. And that was an experience, and we had quite a variety of experiences for the 29 people who were in the study. As you can see, there's 2 different examples I'm giving here, with the red dots indicating what we measured in clinic, the forced vital capacity in clinic, and the blue dots, the forced vital capacity that we measured at home. And I want to point you to the second one, the one on the right, showing that we captured this person falling below 50% FVC approximately 50 days before we would find that out in clinic. So this was a really big motivation for us to do this. This person was able to start their non-invasive ventilation, which they needed, 50 days earlier than we would have identified it if we had just done measurements in clinic. So we had 17% of people meet that endpoint. Did we identify drop below 50% FVC outside of the clinic? And from those 17, 6 had NIV initiated based on the result of their home PFTs. So it's a smallish percentage, but we think it made a big impact for these people who would not have started their NIV until their next clinic visit. So I think the message from that study is that regular monitoring could allow for more proactive identification of patient needs. And we saw that those who had the biggest benefit of home monitoring were those who had lower baseline respiratory function. So for clinicians to consider if they wanted to do this, those are the patients to target for home monitoring of FVC. The next study I want to talk about is our measurement of stride and gait and fall prevention inside the clinic. Walking speed is a predictor of falls. We know that walking changes occur very commonly in ALS, and that it's demonstrated by a slowing of the gait, which can lead to falls. So we used that little white sensor. It's not quite the, the home monitoring device that was shown before, but you're seeing it attached to the foot here, and you're seeing the data that we get from someone doing a 10-meter walk task 3 times. That's their foot going up and down on the 10-meter path. And what we showed is that the walking speed corresponds to the functional rating score and also whether they're using an assistive device or not, a cane or a walker. So again, following the same theme, this motivated us to do a home study where they used these sensors in the home for 6 months. Twice a week, they were told to do a 5-minute recording. And unlike ALS TDI, who had hundreds of participants, we've got 9 here in our study. But we're showing you that in these 9 patients, some of them didn't have any changes in their walking speed, the ones who don't have a red line, and some of them did have a significant change in their walking speed. So the vertical axis on all these plots is the walking speed, and the x-axis is the time into the study. I want to highlight one of these individuals. This is their walking speed on the bottom over the course of the 6 months of the study. The blue ones are the ones that happen first, all the way to the yellow ones that happen later. And you can see that not only do we see a regular and fairly precise estimate that their walking speed is changing over time, but we can see that it's mostly due to stride length shortening and also the stride duration increasing slightly. So you can see from the top plot that we tracked kind of stride length and stride duration separately. So what we found with this is that these objective measures of gait are potentially more sensitive to other measures that we use. Notably, this person didn't have a change in their functional rating score over this time, walking functional rating score over this time. So the lesson from this is that objective data that we collect with these sensors may be more sensitive to subtle changes in function. The last group of studies I want to talk about are about other functional measures, functional biomarkers. And this overlaps a lot with the ALS TDI group. We were also measuring speech, which I won't talk too much about, and swallowing and handwriting. And my motivation for doing this is to get a digital ALS FRS. For those people who can't come to clinic, can we replicate many measures of the ALS FRS R with objective sensor-based measurements? So the first one I'm going to mention is our remote swallowing assessment. This is a partnership with 2 other speech-language pathologists at Penn State main campus. And one of them works on spontaneous swallowing frequency. Attach a microphone to the throat. The number of times you swallow per minute is indicative of whether you have dysphagia or no dysphagia. So in the plot that I'm showing here from their previous data, more swallowing per minute means you have a normal swallow function. As you progress with dysphagia, you swallow spontaneously less and less. So what we were doing in this study is we had them bring home a smartphone app, and they measured the sounds of their swallowing. Every week they stuck a microphone on their throat, and they sat still for 10 minutes, they read a book, and they measured how many times they swallowed in 10 minutes. We compared that to the gold standard, which is a modified barium swallow. And you can see in these two modified barium swallow exams, where we're looking at a radio-opaque liquid being swallowed repetitively, between month 1 and month 6 for the same individual, on the ALS functional rating score, it was a 3 at month 1 and month 6. Some changes in swallowing or occasional choking. But as you can see, you can just look at it and see that the swallowing has significantly changed in that time period. I'm not a speech-language pathologist, but ours told me that there's a slower rate of swallowing and there is some residual left in the throat because of pharyngeal weakness. So you can see the opaque liquid that remains in the throat on the left-sided image. I'm sorry, the right-sided image. So what? And then the last plot on this diagram or this slide is the change in the spontaneous swallowing frequency over that same time period. It starts at a rate of above 1 and decreases steadily, although there is some noise in the data, down to a rate of about 0.4. So another example where an objective biomarker might be more sensitive to the underlying changes that are occurring than something that's self-administered or clinician-administered like the ALS-FRS. Same exact story, but with handwriting. We measured handwriting in this person at week 1, and they did it through 48 weeks, but this is week 44's data. During this time, their ALS-FRS score didn't change. It remained a 3, slow or sloppy, all words legible, which is true, but there's an obvious change in the speed and accuracy of this writing. So we think that this might also, and you can see on the right-hand side, they weren't happy with their G's and H's, so they kept writing them over again. There wasn't any cognitive issues there. They were just really trying to get it right. So another potential biomarker that could be more sensitive to functional change. The last one I won't go over much at all, but we also asked them to say Iowa, 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 and we also asked them to say pa, 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 and they read a passage out loud, and we're measuring their articulation rate and the number of syllables they say per second, and we did see that those markers, those digital signatures, correlate with the ALS functional rating scale as well. So based on this evidence, we think that digital assessments could serve as novel biomarkers in clinical trials, which is exactly what Carol told us in the ALS TDI presentation. And importantly, we're always thinking about the patients, so we think they can do this effectively and at a lower burden to individuals in the study, because it results in less visits to the clinical site to do these measurements. So the lessons that we've learned in these studies that we've conducted in our clinical patients is that there's a great potential for digital health monitoring, both in the clinic and outside of clinic. You can capture this data through your own smartphone, through sensors, or just passively with sensors in the environment. It can be used to both improve care and research, but that further validation is definitely needed. The FDA is very hesitant to approve biomarkers digital biomarkers, I should say, unless there is a great base of evidence that these are tracking disease progression. So home assessments, you don't know what's happening in the home. There's always added uncertainty. We're always trying to track down why the dog is barking, and we tell them to put the dog in the other room during the speech assessments, or other things that might happen. Someone's wearing their sensors that shouldn't be. And of course, qualification is needed of clinically meaningful changes in function. So just because I showed that there was that slight regular decrease in walking speed, it doesn't mean that that's meaningful. And the ALS-FRS-R says that it's not meaningful. So I think we need to meet a balance between where that meaning is important. And then, of course, we need validation in larger clinical trials, ideally, to show that these biomarkers could be used to both find a cure for the disease and to improve patient care while we get there. I want to thank our funders, collaborators, our clinic team at Hershey, and other research support that we've gotten from this project. Thank you.